Okay. Okay.
Okay, so a very good evening to all of you. And on behalf of Team IIP Mumbai, I welcome you all to this fifth episode of IIP Mumbai Monthly Connect, Zaraa Hatke, Zaraa Bachke. As we all know that this program features on the second Wednesday of each month on the online platform from 9:30 onwards. And each time there is a little effort to pick up topics which are actually a Jara Hatke. So, kind of out of the box, because most of these we've all read during our postgraduate days and probably heard a number of sessions on the same. But yet, today, when they come into practical implications, there is always a little haze and a confusion as far as the application goes. So, one such topic today that we've chosen is transfusion therapy, confusions, and consensus. I think we all will agree that we should not be too impulsive in pulling the transfusion triggers. And I'm sure that at the end of today's talk, we will all be convinced that the safest way to use any component transfusion therapy is to probably avoid it. And if mandatory, then justify and rationalize the use and use it properly. So without wasting much time, I extend a warm welcome on behalf of Team IIP Mumbai today to the galaxy of experts. And I hand over to our moderator, our very own past president of IIP Mumbai, Dr. Sameer Dalwai, a very dynamic pediatrician, a very good orator, and request him to introduce our faculty today. Over to you, Sameer bhai.
Good evening, and thank you, Dr. Nehal, who's the co-moderator for this evening as well. She's in a double role, and welcome to all the experts. Well, to begin with, what comes to mind is this statement that "तुम मुझे खून दो, मैं तुम्हें आजादी दूंगा." I think this war cry is probably the most synonymous with our patriotism, our nationalism, echoed by the great son of India, Dr. Mr. Subhash Chandra Bose, Netaji. And this call was basically, the words are an idiom, bleed for your country or give your blood. Basically tells us that you have to sacrifice for the country, for the larger good of everybody. But also it means that you can actually literally give your blood in case of a medical issue or in a health issue to actually save the life of a fellow human being. You have no idea where your blood has flown to, but it is flowing around in the eyes, ears, heart, of brain of the person who's carrying that, and is leading a lovely life as well. I mean, that's one of the most beautiful aspects that science and medicine has given us. So those of us who are unfortunate that we cannot be capable enough to serve the nation and give our blood at the borders, at least what we can do is give our blood to our fellow human beings. But that is where a lot of confusion starts, and that is where consensus is needed, and that is the science of blood transfusion. So beyond the donation, what is done with it is even more important, and that is a topic that we are going to look at today, for which we have some wonderful experts. Who doesn't know Dr. Mamta Manglani? She has been a teacher to all of us, either directly at Sion Hospital or K.A. Nair before that, or in some conference or the other. And she is also a very highly decorated clinician, academician, and a researcher. She is the director of the Mumbai Municipal Corporation Comprehensive Thalassemia Care, Pediatric Hematology Oncology and Bone Marrow Transplant Center in Borivali, one of its kinds in India, if not Asia. And the reports and the results that they have and the data that they've published is mind-blowing and makes all of us proud. Of course, we all know that she is a former professor and head and chief division of hemato-oncology, program director, Pediatric Center of Excellence for HIV care, head of Department of Pediatrics, LTMM College and General Hospital Science, Mumbai, multiple awards, 2 Lifetime Achievement Awards, one of which I was fortunate enough to introduce her for, and multiple fellowships all across the world. So, ladies and gentlemen, please welcome our expert for today, Dr. Mamta Manglani, ma'am.
Thank you. Thank you so much, Sam.
Along with that, we have Dr. Nitin Shah, who has instructed me that his introduction should be in one line, a friend of IAP and pediatricians. I'm sure all of us know that he has been the past president of Indian Academy of Pediatrics, and again a teacher par excellence, not just to who is exactly his direct students, but anyone anywhere in need of any solution has to just call out and reach out to him. And like those comics we used to read about Phantom, you ask a, reach out to the Phantom, and those tom-tom, those jungle drums ring, carry the message there. So somehow or the other, with this online network, you get hold of Dr. Nitin Shah and your problem can be solved. And of course, today, thank you for joining us, Dr. Nitin Shah, sir. And ladies and gentlemen, please welcome him. And today, we have somebody who is the pediatrician's point of view, who's going to give the pediatrician's point of view, none other than Dr. Anupam Sachdev, another past president of the Indian Academy of Pediatrics, one of the country's first pediatric hemato-oncologist who set up a fantastic branch and fantastic department at Gangaram Hospital. And again, you will go to every city and you will find, if you are talking to a hematologist there, you will find somebody who has trained with him. And the point that I'm saying today is unwell even today, but we are fortunate in IIP that there is certain temptation we can give these people, whether it is Dr. Nitin Shah, whether it is Dr. Mamta Maglani, and especially Dr. Anupam Sachdev, that if you tempt them with teaching, वो भौरा जैसे फूल के आता है वैसा, they will always come to any academic session. So ladies and gentlemen, please welcome Dr. Anupam Sachdev from Delhi, and we are so happy to have all of you with us today. And of course, also welcome my co-moderator for the day, Dr. Nehal Shah. She's an eminent pediatrician. We have studied together at JJ Hospital, and one of the most sweetest,
Samir,
nicest.
we'll lose 2 more minutes. That's okay. And I'm almost feeling like 3, 2, 1 live on air because looking at these giants, madam and sir, it's always difficult to be on the panelist side and answer questions. But I think today it's going to be a test of asking the right questions also with these two masters. So I think let's begin. And Samir, you can start the session.
So
Absolutely.
Nehal, I'm going to ask question to you also.
Okay, sir.
So since we are going to ask
Joking,
questions to each other, let's all begin with some basic generic points about transfusion therapy. And I'd like to ask Dr. Mamta Madam, the basic simple question, how much volume of blood should be drawn from a donor?
So generally, Samir, it is, first of all, let me thank both of you, Nehal and Samir, and the IIP Mumbai team for having this session and having me here as an expert. I'm not sure whether my memory will stand the test of time because it's difficult to recollect everything that you ask. But to make the answer simple, generally a donor has to be bled 350 to 450 ml of blood. And it varies because some people prefer lesser. Like in India, mostly we take 350, but abroad they take up to 450 ml.
Okay, so that's very clear. So again, like moving on to Dr. Nitin Shah, sir, what are the main tests you need to run on the donated blood? What is the protocol? Because we have all these concerns about safety,
Right, absolutely. So I think even before you collect the blood, some safety has to be ascertained by the questionnaire that is given to the donor. So like if you anytime go as a first time donor, you will have some 20-25 questions, which will include your recent illnesses, your recent drug history, your sexual habits, etc. Basically to pinpoint that you are not suffering from anything, you are healthy. So suppose you were on antibiotic or you had diarrhea or you had fever, you have to wait for at least 1 week after all that is stopped before you can be taken for transfusion for donation. And so that is the prerequisite before the donation is started. Then your BP is checked, then your condition is checked, your hemoglobin is checked. If they are all okay, that means you are now sort of healthy, and then your consent is taken and you have then taken on the table to donate the blood. Now, after having taken the blood, the mandatory tests, which are of course besides the ABO and RH blood group, are the 5 infections that you have to test for. That is HIV, HCV, HPV, that is hepatitis B. Then you do for syphilis and you will have to do for malaria. So these are the 5 tests which are mandatory. Now, how do you do this test is up to you. A good blood bank will do a net-based testing, which brings the window period to almost very few days, almost like saying 0 chances of transmitting a viral infection. But if not, then at least not an ELISA, but a chemiluminescence test should be done for these 5 infections. But still, the window period cannot be blocked to as low as that is done by the net testing. So these are the tests you should do. You will of course check the hemoglobin, the hematocrit of the donor after you have taken the blood, and that's how then you will store. You will of course also make components out of it and then store those components.
So is NAT universal now? Most of the places are they doing
So
NAT?
good blood bank will have NAT. It's not universal.
Okay.
Minimum testing is by ELISA or chemiluminescence. Good blood bank will do NAT. Like India is doing NAT testing for more than 20 years now. The idea is that for HIV, the window period is blocked from 14 days by ELISA to 2.9 days.
Wow.
For hepatitis B, from 30 days to 6 days. And for HCV, from say another 10, 14 days to 3 days. So you can say it's almost like first 3 days. And
Close
if
to
you tag to that the history of your sexual behavior, or you have not taken any IV drug abuse or a recent transfusion, it is very unlikely you will then
Reasonable.
transmit this disease. It's said that by that testing, the entire UK, there will occur one case of HIV in spite of net testing, maybe in 1 in 20 years.
Wow.
So that is the type of safety that you're talking about.
Lovely. Thank you, sir. Quick questions from our very interactive audience. Dr. Kaushal wants to know any about blood donation and diabetes. Is that a contraindication?
Whom you want?
You can answer this.
Okay, so a well-controlled diabetic person
Yes.
can donate, but if he is not controlled, then he cannot. Also, what medications he is taking is important because certain medications they would not accept the patient, but most of the anti-diabetics are accepted. Even
Same is for
hypertension,
hypertension.
yeah,
Yeah.
same. If they are well controlled, there is no contraindication.
If you are on
But-
anti-thyroid toxic drugs or
Yeah,
onco drugs,
chemotherapy, yeah.
then you should not be. Then you are not fit to
Yeah.
donate.
What about test for CMV?
So test for CMV, Nitin, you want to take it?
No, it's universally it is not done. But if you have a transplant setup and the recipient is CMV
Recipient.
negative, which is going to be again rare because in our country, you will so by first few years of life, 98, 99% are CMV positive. So if you are CMV negative recipient, then you will not want to infect him and have trouble during a transplant setup.
So CMV negative or positive, both, Nitin, we will like to know the status and use CMV negative blood for transfusion in such cases.
Yes.
Because even if the recipient is positive, reactivation will occur if you use a CMV negative donor, and you will have to worry about that. But yes,
That'd
CMV
be very difficult to get
negative
one.
recipient, yeah, you do not. Actually, we hardly had CMV negative recipient in
Practically.
All right.
themselves. Right.
So, our dear friends, we love the fact that you are so proactive and sending in your questions. We'll try and take as many as possible. But my next question is Dr. Mamta Maglani. Now we know that it's not just the RBC. So what are the various components that can be derived from the donated blood?
So in a donated unit, you have the fresh frozen plasma, you have the RBCs, you have the platelets, and you have the cryoprecipitate. These are the major components. Of course, besides this, there are many proteins which we can derive from a blood bag, such as you can get IVIGs, you can get albumin, you have fibrinogen. So a lot of things can be derived. Not fibrinogen per se is derived as a separate fibrinogen concentrate, but it is one of them. And these are the factors also, the plasma-derived factors, coagulant factors can also be taken from the plasma. So these are various components, but majorly you have 4: plasma, cryoprecipitate, RBCs, and platelets.
So one person can actually save the lives of so many.
Essentially, a blood unit collected in the blood bank will be fractionated into packed red blood cell and the platelet-rich plasma, which will be further fractionated at a very high speed to platelets and fresh plasma. That fresh plasma then will be pooled together and stored as FFP. From that, then you can either use it as FFP, or you can make cryo, you can make IVIG, you can make albumin, you can make so many other things.
Lovely. So moving ahead,
Samir, another component which is not usually used by pediatricians is granulocyte concentrate, which requires specialized preparation and this thing. So that is more, we are more versant with it because those who are doing transplant and all.
Yes.
But even in the neonatal unit, some of the people have used it for severe infections.
Yes, I agree. I missed on saying that, but that's more with apheresis and not with the regular blood donation bags.
Yeah.
Thank you, Dr. Anupam sir. Thanks, Mamta ma'am. So, Dr. Nitin sir, now once the blood has been called for, it's already there in the blood bank, and you've called it to the ward now. What is the checklist to be followed when the unit is received in the ward for use? Because we've heard of some very scary stories. You know what I'm saying?
So when the blood comes, two different people have to certify on paper in writing that if the correct blood for the correct patient. And mind you, there might be two different patients of the similar name and even similar surname. So they are identified not only by the name but also by the hospital number. We usually it will be an indoor patient, so there will be a hospital number, and then the correct blood group is there of the patient and of the blood that you ask for, or a compatible blood group that has to be checked. The volume has to be checked. The expiry has to be checked, and you have to see the bag for any visible contamination or a visible break, especially when you use the FFP, because it's frozen. Sometimes the plastic bag might have cracks there. So all these are to be seen, and they have to be certified on paper in writing and before you start the transfer.
Okay, thank you so much, Dr. Mamta Mang. Back to you again. So, is grouping along with cross matching mandatory each time in a child with TDA during each visit? And like, what is a double cross match?
So first, let me allude to a grouping is mandatory in every transfusion, even for a transfusion-dependent anemia, because you want to confirm that the sample that has been sent belongs to the same patient, even if you know the blood group already. And cross-match, of course, should be done every time, especially a Coombs cross-match in every patient who's receiving multiple transfusions, because you can have alloantibodies formed due to multiple transfusions. So both are required. A double cross match is mainly required for a neonate below 4 months of age, where you want to identify the antibodies that might have got transferred from the mother to the baby. And therefore, you do the grouping of the child, you do the cross match with the mother's serum or plasma as well as the baby's. And whatever is compatible with both the mother and the baby should be used as the transfusing bag, especially ABO group of the baby, RH negative preferably, or of the baby should be used. So this is how one would do a double cross match.
Madam, any special clinical situation that you would say where this is very implied, the double cross match?
So in any, actually in RH isoimmunization, when
even
you're
an
using
exchange, you need to be very sure.
Yes, you have to be sure. And in any condition where antibodies are suspected to have been transferred from the mother to the baby. For example, even not just alloantibodies, but any atypical antibodies.
Any baby up to 4 months of age is reflection of also the mother, because the half-life of the IgG transmission from mother to the baby is significant till 4 months. So you have to not only newborn but even later up to 4 months.
Yeah.
Can I come in for a second here?
Yes, please.
Couple of points. One is that NAT testing is still not universally available across the country, and very few centers are having a sustainable NAT testing. This happens especially in the public sector rather than in the private sector, because private sector is more robust from the sustainability point of view, because the patient is paying for it. So now there has been a virtual in the last 1 decade, there's been a virtual increase in in transfusion therapy and in the facilities available for transfusion therapy. And I was just going through the website of the blood cell of Government of India, and if I'm not mistaken, even in the state of Maharashtra, there are over 560 blood banks registered with the blood cell of. So the situation has changed drastically in the last 2 to 3 decades, where we used to sort of have a lot of difficulty in getting blood. The problem is still that there are, even in your blood bank, you will have problems with a particular blood group, with a particular patient. The scenario is rather dismal as far as voluntary donations is concerned. Majority of our patients are still getting replacement donors. Majority of the blood banks are still getting replacement donors, and it is becoming, although the number of voluntary donors is going up steadily, but still a lot needs to be done, because the risk of infections and other problems with replacement donors is far higher than that of voluntary donors. So, I mean, these are some of the ground rules where we have to operate, in the sense that the constraints of the system which are there, and I'm hoping that in another decade's time, the whole system will get streamlined and the government is very particular about it, with a separate area in the Ministry of Health and Family Welfare, which has come up in the last 10 years as far as blood cell is concerned.
Yeah, so especially with transfusion dependent, I mean, we know about all this. Now, we've been asked a question here, Dr. Sharan Shetty, how safe are mobile blood banks? There are vans packed at traffic signals urging us to donate blood. So, we are not sure whether this is authentic, safe, helpful. Any answers to that?
So it's not a good idea to have these kind of donations, because you will not have enough time to do the stringent donor screening by the questionnaire, and therefore it will be hurriedly done. It might lead to some professional donors getting into it, and they will not be always healthy donors. But then we have constraints of having blood sufficiency over the country, and therefore certain such steps are being taken in desperation. But ideal should be having huge metropolitan blood banks in the cities, and single blood bank which provides for the whole city or even sometimes for the whole state, which is a difficult thing. Like New York has a metropolitan blood bank which supplies to the whole city. So that is a concept which is not picking up in our country soon. But I'm sure with the blood cell in place in the Ministry of Health and Family Welfare, we are moving towards these steps. We need to work much harder for achieving that.
So, quick answer from both of you. If a person has either a sickle cell trait or a thalassemia minor, can they donate blood?
They can donate. Nitin, you want to take it?
No, so thalassemia minor, certainly if the hemoglobin criteria is met with. Sickle trait also has really no problem because he himself is asymptomatic. But if someone has sickle cell anemia, then of course he will not probably match the criteria, but even if he matches, it is not to be taken. And that will be picked up on the peripheral smear that is seen after the blood collection. They then see the sickle cells.
Okay. So, Nitin bhai, are there any special situations where like you want to give a talk or tailored instructions to the blood bank and talk to them, like as fresh as possible or something like that? Are they? Would you want to pick up the phone and talk to them?
All right. So there's nothing like fresh blood. All right. All blood have to be made into components within 6 hours. Because as you know, factor 8, factor 7 have very short half-life. If you wait for too long, they will disappear. So the whole purpose is defeated. So there's nothing like fresh blood. There's nothing like Amar Akbar Anthony type. You donate, you bleed someone here and connect him there. So what is whole blood rather than fresh blood is also a reconstituted whole blood. So when you discuss the whole blood, we will talk as to how you reconstitute the whole blood. But there's nothing like fresh blood. Yes, but in general, intrauterine transfusions, exchange transfusions, ECMO, where there's massive blood circulation, or a massive blood loss where there is a huge, like more than one blood volume loss in 12 hours, or more than 3 cc per kg per minute type of bleeding, or a patient with massive cardiac or orthopedic surgery where there's massive blood loss. These are the patients who should not be given a Paxil or a platelet or whatever. I'm platelet, of course, you don't give more than 5 days old, but Paxil, which is more than 5 to 6 days old. So that is the only way, that is the only as fresh as it can get. But there's nothing like give me only 48 hours old or 24 hours old blood. No, you can't demand like that.
So
okay, so I think
it is not required. Yeah, sorry, go ahead.
No, please complete.
No, so I just wanted to say that other special thing is in a patient who is going to need multiple transfusions, your problem is rare blood groups. And like suppose I am B positive, I could also be say KEL negative. Okay, now I won't have a ready-made antibody against KEL. Like I don't have RH antibody against me if I'm RH negative unless I am exposed to an RH positive cell once in my life. So now if I have to receive again and again, and second, third time, I might have anti-KEL antibody positive blood given to me, which will break my KEL positive. I will be sensitized to KEL and develop antibody, which will then kill the donor cell which are KEL positive. So how do you circumvent this problem in multi-transfusion? There are two ways. One, either at the first transfusion itself, you should do a phenotype antigen of the RBCs. You don't need to do ABO and RH. You also at least do the complete RH and the KEL. I mean, that is what Hinduja does. Okay. And then you transfuse. And then every time patient is transfused, patient undergoes what is known as antibody screen. So you take patient's serum initially put a 3 RBC cell line, which are each coated with more than 6-7 antigen. If the patient blood has some rare blood group antibody formed because of previous exposure, that test will become positive. You know, at least he has got some rare antibody. Then next you take a set of 11 RBCs, each tagged with 111 antigen, and you again repeat the sample, you know which antibody it is. So from the pattern and the type of reaction, you can pinpoint what is the red blood group which is negative in the donor, which is leading to sensitization and a future problem. So any good laboratory blood bank would do a antibody screen before every transfusion, especially for multi-transfusion.
So
I think
basically, sir,
that's the way
transfusion dependent.
that's the way you can actually, like I'm telling you, you are thalassemia who are transfused 500 600 bags and still they don't break any time, because moment you find a red blood, like suppose is KL negative, then you will search an ABO RH compatible KL negative donor from your fridge, and you
Right.
may have some dedicated donors for them in case they require it again and again. So there are ways by which the blood banking has become more and more safe.
Sure. So let's
Dr.
move
Mamta
on
was saying
to
something.
Madam was
Wanted to
saying
say,
something.
अच्छा भूल गए, चलो ठीक है. Next question.
Okay, so let's move
हाँ.
on from the general principles about blood transfusion to now specific component therapy. And let's talk about the most practically used, indicated, and most important precise practices to use the packed cells. So, Madam, beginning with you, can you tell us the, I won't say indications, but advantages of packed red cells over a whole blood?
So as we know that packed red cells are a targeted therapy for those who have just lack of RBCs or anemia. So there is no need, first of all, to give other components. When you give whole blood, you are giving the white cells, you are giving so much of plasma with plasma proteins, which will then cause so many reactions. And unnecessarily, you are increasing the volume also. These are the reasons why you would prefer. And if you give only packed red cells, the volume goes down. It is more efficient because the hematocrit is better and you reconstitute it as you wish, as per the hematocrit you desire. And then you know exactly how much will be the rise in hemoglobin in that patient, and the patient will receive less volume, more efficient transfusion.
So any specific hematocrit of the packed red cells that you recommend generally on a uniform basis, apart from some kind of cases where you would demand a little lower or a higher hematocrit? So in other words, what is the ideal hematocrit of most of the packed red cells that we order?
Most of the packed cells have hematocrit of anywhere from 65 to maximum 70, not more than that. If you pack it too tight, then the nutrients will suffer and the RBC may undergo hemolysis. In a newborn, you should be careful because you may lead to polycythemia, as the baby is already having a very high hemoglobin. You may even make the packed cell hematocrit to around 55 or 60, like in an exchange transfusion. Of course, as I said, we do reconstitution of the whole blood. So you typically it is kept at 50, 55. And with a compatible plasma suspended in a sterile way and given it to you as a whole blood. So when you ask for exchange transfusion whole blood, it's actually not a whole blood. It is a
It's a
reconstituted whole blood.
reconstituted thing.
And there is no
So, but
platelet
apart
given.
from this special case in a newborn, where as you rightly said that we are going to reconstitute and make it something like a whole blood for exchange
Correct.
to a whole blood,
So
I mean
not,
partial.
so not only that, all these indications, exchange transfusion, massive blood loss, ECMO, severe cardiac surgeries, very high bleeding type of orthopedic surgeries. These are all the indications, and of course, massive transfusion and trauma, or like say varices comes bleeding like a tap.
Right.
That's massive. All of them are given reconstituted whole blood. So it's whole
Right.
blood, but reconstituted. And
right,
when
sir.
you are doing for exchange, you don't give platelet, you monitor the platelet count. So there's no need because you're going to do only 1 or 2 exchange, right? So it's not going to really dip the platelet count. But in all other conditions, even when there are platelets, they are dysfunctional because many of these products will have some platelet. So you will have to actually give 1:1:1 ratio of packed cell,
Right.
FFP and platelets.
Right. So, but standalone packed red cells, we are okay if this comes as 65 hematocrit, and we don't see any other clinical situation for us general pediatricians where we can demand que go for a lower or a higher hematocrit.
No need to do that.
Madam,
In fact, good hematocrit packed cell, the volume will become so less to rise a serum hemoglobin that actually is beneficial even if the patient is in threatening to go into congestive cardiac failure.
Right.
And the way to go in a congestive cardiac failure is to not to give slowly, but give less small volume to start
Small
with.
aliquots.
And after
small
6 to 8
aliquots
hours,
and finish
make it so 5 cc per kg, make it another 5 cc or 10 cc, and gradually build up.
So, madam, can you tell us the estimated rise per ml volume of the packed red cells to a hemoglobin gram
Yeah,
rise.
so generally 3 to 4 ml of packed red cells will raise the hemoglobin by 1 gram % of packed cells, and whole blood 5 ml will raise by 1 grams. Of course, it depends on the hematocrit. As I said, it should be adequate hematocrit. Nitin has already alluded to that, 65 to 70%.
I always
And
teach
in
the
terms of
students,
volume, sorry, sir.
I always teach the student that in a thalassemia, suppose you stop your bone marrow shuts today. What's the drop in hemoglobin? Is 1 gram per week. So in a thalassemia, when you call him every month, there is a drop of 4 grams. You need to build a 4 grams, so you give SF5 cc per kg, it rises by 1 gram. You give 15 to 20 cc per kg of packed cell, and again it will raise the hemoglobin by 3 to 4. Again, it will drop in the next month, and this cycle will continue. You don't have to memorize it unless if you remember the basis behind.
Absolutely.
And sir, the volume of packed red cells that we get is fixed about, would we say
So
150
it's
ml?
never. You mean so one
The
packed
volume
cell
of
is
one unit
okay.
of packed red
So
cells.
1 unit of 350 cc or 450 cc, depending on what you have collected. Remember, when you have 350 cc of blood collected, there is 16 cc per 100 cc of anticoagulant. So almost 56 cc of anticoagulant in the 350 cc. So actually, there's only 300 cc of blood in the 350 cc pack, right? And if you say the correct hematocrit of 45%, so you are actually having only 220 or 225 cc of packed red cell in that.
Packed red cells.
And packed cell can't be made without any plasma at all. There will be some plasma. So generally, you get 200 to 220 cc,
Okay.
maximum 250 cc of packed cell per unit that you ask for. But if you want for smaller babies, you can
Right.
ask for a smaller allocate. In fact, a good blood bank will always keep pediatric and neonatal practice in mind and have a pentavalent bag whereby there are
Right.
2 more satellite bags to make that 220 cc 250 cc packed cell into 3 bags. So they have 80, 80 or 70, 70. And even from that bag, if you want only 20 or 30, they can still give it.
Right.
Because there are sterile connector available which can make another 4 satellite bag from a bag and give you the exact volume that you need. So you should
that would
not
be the
waste.
same case in the other conventional blood banks, that suppose you are not getting it in the hospital and you order it from outside. You order
So
for a
a
pack
good blood bank should give you the alicate that you need.
aliquots as
Many
well.
may not be. They will say you waste the remaining. We have no mechanism of giving you 100 cc or 80 cc like that.
Right, sir. So coming to you, sir, especially about the transfusion dependent anemia states. You
Correct.
rightly said that there are few investigations that are mandatory when you have a diagnosed case of a transfusion dependent anemia. And before you give the first transfusion, you want to run these on the patient. And then definitely every time that he's receiving blood, you want to run certain on the units also that he's receiving. Now, suppose this is a child where he has already received a blood transfusion at a periphery. Before
Correct.
he's come to you with, he's still not diagnosed. So
Correct.
what happens to the blood picture? So in other words, how much time do we wait till we want to do a definitive diagnostic screening on such a patient? What do we miss out on? What do we mask?
Of his thalassemia or of the blood grouping and the cross matching?
So the commonest we are looking at thalassemia part,
No,
but
so you
also
want
for
to you have a problem of diagnosing thalassemia after someone has received transfusion
yes,
and come
sir.
to
So,
you. You
right,
can
sir.
you can do genetic test today. Previously, we used to wait till hemoglobin falls to 5 or 6 and allow the patient to wipe off all the transfused blood and then you take his for hemoglobin electrophoresis and all. Nowadays, we don't do it. We do genetic tests. If you do
Right.
of the index case of the both the parents, the child has both the mutation, he's thalassemia major. If he has one or none, then he's minor or normal.
So apart from hemoglobinopathies, sir, if there are any other hematological conditions where we've missed out on a diagnosis, the child has just come to you after a transfusion. You
There
think
is no
some
problem.
tests
Like
are going to
sickle cell and all, there is absolutely again.
electrophore. So
Yeah, electrophoresis.
hemoglobinopathies is out, sir. I'm talking
Okay.
about the other hemolytic anemia
So, like if you
states.
have a patient of leukemia and someone has given transfusion, he will be in remission for 3 months. You will have to wait till his
Exact.
hemoglobin platelet will drop. So, each
Right.
individual condition, it will depend on what they're looking at.
Okay.
So, other
Okay.
transfusion dependent sites are like diamond black fan, Fanconi's anemia, or bone marrow failure like acquired aplastic anemia. They will all be evident very soon.
Okay. So
So
can we
there is a
understand, sir, that probably in between 40 to 60 days, it'll be a reasonable time to pick up in other
absolutely.
conditions
Let
apart
the
from.
hemoglobin drop to less than 7, and then your primary disease will be more easily accessible. But suppose you are suspecting aplastic anemia, you don't have to wait, just do a bone marrow.
Right. Right.
Suspect Fanconi, don't wait, do a bone marrow and do a genetic test.
Right. And so then
But
these
more than that is the rare blood group because they are multi-transfused. So if a patient, in fact, Good blood bank again will do an antibody screen in every transfusion, not only
Tremendous.
multi-transfuse, every transfusion. Every time you will ask for a blood for whatever reason, surgical, otherwise, they will do an antibody screen first. And if the
Right.
antibody screen is positive, they'll try to find out which is that antibody which is going to create trouble for you.
Right. So the other question in this group, the transfusion-dependent anemias, now that we said that nucleic NAT is not very common and still we are with ELISAs and maybe sometimes chemilucin. So do
Correct.
you in these patients order a viral screening every periodically, and what would that period be? Suppose I want to
So-
pick up this person who was missed in the window period.
Correct. So like I practice in Hinduja, we never do ELISA for HIV, HBsAg, HCV. If they have received transfusion right from day one till day end here, we may do once in a year, once in 2 years, or if they become symptomatic. But I'm sure when we were in Sion, Dr. Mamta will agree, when we were Wadia, a lot of HIV, HBsAg vaccines were not there, hepatitis B. We used to do every 3 months. But I think
Oh,
probably here you will do once in 6 months to once in a year based on what type of blood bank the patient has taken blood from.
So the recommendations by even TIFF and our own guidelines is annually.
Correct.
okay, annually. Right, sir. Right, madam.
And of course, if someone is symptomatic clearly, has deranged liver functions, then HCV should be ruled out, HBV should be ruled out. That's a different story.
That will be
But-
from case to case. But as an
Yes.
overall
Yes.
protocol, it would be
Yes,
annually that if you want to
annually.
pick up, because these are all going to receive multiple
Absolutely.
transfusions and you don't want another chronic disease setting in.
Yes.
Okay, so we'll move to some real life scenarios now. Madam, beginning with you. So, what level of pre and post transfusion hemoglobin is ideal in transfusion dependent anemia states? And obviously, we are talking more about what is most
Common.
beloved to you about thalassemia. And would there be any upper level of the post transfusion hemoglobin that you don't want to cross?
So first of all, post-transfusion hemoglobin is not at all taken into consideration. The mean pre-transfusion hemoglobin should be maintained at about 9.5 gram % as per the latest guidelines. So every time a patient comes, you do the hemoglobin before you give the next transfusion. And it is between 9.5 to 10.5, you go ahead and give a transfusion.
That would
If
be
it
3
is-
weekly. Sorry, madam. 3
Yeah,
weekly.
3 to 4 weekly, depending on how the patient is
Patient to
behaving.
patient.
Younger patients require 4 weekly, sometimes even 5 weekly. They don't drop so quickly, whereas older patients require, and also the type of blood you are transfusing, the donor blood. So as we
Quality.
know, ideally we should give 5 to 7, not more than 5 to 7 day old blood for thalassemia, because you want a good lifespan of the RBCs that you've
RBCs.
transfused. But older RBCs will naturally have a lower lifespan. So ideal donation of before 5 to 7 days will give you 90-day lifespan by and large, 80 to 90 day, unlike 120 days, which is in a normal healthy person. So if you want to maintain that, you give good fresh blood. What we were debating, that fresh blood is not a real requirement, but here we suggest, but we don't get. The post-transfusion hemoglobin upper limit is 14 grams ideally, not more than 14 grams. You don't want to create hyperviscosity and have problems with that. So, but we never do a post-transfusion.
We don't do it in
because-
practice really.
No, it can be done 24 hours later, because then the
We wait for the hemodialysis.
homeostatic stability can occur, and then you can.
It's not the standard
sir-
of care. Please don't
No,
torture
it's
these
not,
children
it's
with
not.
another prick.
It's
They
not.
already have
Right,
so
right.
many
No,
pricks
no,
in
no,
life.
no. We
Right.
never do it, as I said.
Yeah.
We never do
Right.
it.
Right.
Theoretically, I told you.
So you will
Right.
probably do it only if the child suddenly looks pale, but then you're doing it for the condition, not to
Yeah,
demonstrate.
yeah.
Then
Yeah,
here's
it's
the
Not
minor
as a
blood group,
protocol. Not as a
delayed
protocol. We will never
hemolysis,
recommend. We'll just do a
correct.
pre-transfusion.
hypersplenism,
That'll
all
be 3 to
those.
4 weekly.
Yeah.
Anyway,
sir-
if we follow the protocol which Dr. Nitin Shah suggested of 20 ml of packed cells, and your hemoglobin was 9.5, this will raise it only by 4 grams, the hemoglobin by 4 grams. So we really don't advocate post-transfusion hemoglobin testing at all,
Right, sir.
at all.
Sure, sir. Got it. Nitin Shah, sir, can you highlight few methods just for us, our common knowledge, to prevent the least risk of infections or reactions in all these transfusion-dependent anemia states? So
Correct.
would you recommend certain type of packed red blood cell units that we can specifically order and protect them?
So the common infection that can lead to a problem after transfusion is immediate, which if there's a contaminated blood, obvious sepsis can happen. There's a crack which you have missed, or an unscrupulous blood bank had very unsterile ways of collecting, etc. You have kept the blood hanging in this hot water weather for 8 hours. There is nothing like allowing it to become warm. The blood bank will warm the product which need to be warm before they giving to you, and packed red blood cells need not be warm unless in newborn, preterm, that too, where the hypothermia can happen. Because imagine you are giving say 300 cc of packed cell over 3 hours in a child who is otherwise absolutely normothermic. That blood is getting diluted drop by drop. So really there's no need. So don't keep on hanging and finish your packed cell in 3 hours. Don't wait for 4 hours and 5 hours and 6 hours. That itself will be enough to lead to problem of immediate infection. Then of course all your testing of HPV, HCV, HIV, malaria, etc. will rule out all that. And then comes the question of late like CMV, EBV, which can happen in an immunocompromised host or in a transplant setup. So there you will be more careful. And moment you are suspected, you will do the CMV PCR, CMV viral load copies, and so on and so forth. So
So
this is the way.
specialized methods like leukodepletion and
So that's
radiated.
one. So now for I mean, one is of course the intra cellular organism like CMV, EBV, PARO, etc. are all in lymphocyte. Lymphocytes have no role to play in the child's life. Those lymphocytes can actually lead to HLA sensitization. If he's a future transplant recipient, it can lead to havoc with the transplanted material. And lastly, it can lead to non-hemolytic febrile transfusion reaction. So many bad things can happen, including a lung injury. So those lymphocytes have no role to play. Absolutely, they should be removed. So that's why you leukodeplete most of the blood product. And it's a standard of care that in like Hinduja, we'll always get leukodepleted. We don't have to ask
So
for
at
it.
the filter or at the
So
collection?
it is in when the blood is collected, it is collected in the anticoagulant CPDA. That's what we use, CPDA, and then we collect the blood. Then that blood, when it's fractionated, the paxes are run through a line filter. So it will filter out most of the lymphocytes in that pax cell. But the plasma, platelet rich plasma which will go, there is no way to filter out WBC because those platelet filter which were available for inline filtering are no more available. Because the use is so low, the company has stopped manufacturing. So there, if you want, you have to use a bedside filter for platelets. For plasma, anyway, it doesn't matter because plasma is fractionated and all WBC buffy coat smear is removed. So by leukodepleting, so these are the ways. So poorest leukodepletion was saline washing, 3 times saline washing in a centrifuge, which would reduce it by 92%. Then you have
55.
bedside filter, which are expensive. So and every unit has you need a separate filter. So they were like not in vogue. So we use inline filter, which removes it by 99%. But for patient who can still get into trouble with that 0.1%, like immunocompromised, transplant setting,
Right.
like
Candidates of-
intrauterine, there you have to gamma irradiate. So these are the ways
Right.
by you can remove the lymphocyte and the lymphocyte associated toxicity, including the infection that you were talking about.
Right.
The
So here
best
I
thing-
would
add,
Dr. Mamta
So the
also.
best thing to
Yeah.
do is to do the pre-storage filtration. That's
what
the
he was
best.
talking.
And that is done in the blood bank rather than at the bedside. The risk of NHFTR, that is non-hemolytic transfusion
Fair.
reactions, is much more with inline filters, bedside filtration, than with, blood bank pre-storage filtration.
In fact, Anupam, we have
So-
thalassemics who have received 600 transfusions so far in Indonesia. Not once they had fever with any transfusion.
Yeah, sure.
That is the idea of inline filtration.
No,
Dr.
so
Absolutely.
absolutely, Nitin is right, and Anupam is also absolutely right that pre-storage filtration is best because it also doesn't allow the cytokines to be available to cause the reactions. But they are not practically available. Pre-stored leukodepletion is not available practically to everybody. So the least
Absolutely.
one can do is use an
Leukocyte filters.
inline leukocyte filter, bedside rather.
Bedside.
And in the bedside filter also, there is a good efficiency of almost 99.9% removal of
Yeah.
leukocytes. But as I said, the cytokines would have been released already during storage, and that can still lead to
Right.
NHFTR.
Right.
In fact, we had done a study where we had NHFTRs of 13.2% before we were using leukofilters. We were doing only triple saline washing in cyan. And when we started using leukofilters, it dropped down to 3%. So there was a huge drop, though it was not zero or negligible, but it was quite low. And therefore, if you are at least not getting pre-storage filtered blood, please use
At least
bedside
use. Madam, about
leucofilters.
800
But-
to 1,000 rupees per filter.
Yes, it is about
They
1,000
are
rupees.
expensive, right?
Yeah,
So-
but
And-
if you're
In
taking
fact, the
pre-storage
cost-
leukodepleted blood bag, they charge you for that.
Oh,
The
Yeah, yeah.
bags are
The
very
extra is-
expensive.
right,
The
right,
bags
right.
are
In
very
fact,
expensive.
the cost,
But
Yeah.
cost of pre-storage filtration
higher.
is more
Much higher.
more than the cost of bedside filtration.
Right,
Yes,
right,
it's
right.
about
But-
3,000 rupees for the
But
bag.
Bantu, you should remember now
So
the
going-
State Blood
yes.
Bank has decided on the charges, what you can charge the patient for each blood product.
That's for
So-
thalassemia.
So now but most of them are
Yeah,
others
yeah.
don't bother because
Don't
you don't
bother.
need to use filter in otherwise normal person.
Yeah.
I mean,
So I'll just go back
there
to
are ways
highlight
there are
one
ways
thing for
hospitals circumvented. I don't want to discuss it.
Yeah,
So
understand.
I would like to highlight one thing to all
Yes.
our viewers here, as you said, but maybe we missed it. That was a question coming up, that we don't need to hang and warm any units that come to us. They are readily done by the blood bank. So when they are received at the recipient end, they can be used immediately, right, sir?
Immediately they should be used.
And
Don't
in
store it in the
case-
refrigerator.
No, don't store in refrigerator.
Including FFP when we discuss it.
They thaw
FFP
inside.
should not be thawed bedside. It should be thawed by the blood bank and
Yes.
7 degree in a water bath and
Right.
given to
Water
you.
Sir, so we will, with permission from both of you, we are coming closer to ending. So we will take whatever we can do today and we'll just go on.
Yeah,
So we
yeah.
can cover up most of the questions.
Sure.
Madam,
Yeah.
ये
with
कौन है बात कर
I
रहा है?
think
Can
someone
someone-
has to mute him. Dr. Alam should mute
Can
himself.
you someone
please.
mute host? Can you mute everyone except us?
Please
Yeah.
mute
For,
yourself.
typical deficiency anemias, I think this is one
Yeah.
common thing that most of our pediatricians see. A child is having a hemoglobin of 4 gram %, but he's stable. Would you recommend a blood transfusion?
Unless there is impending cardiac failure,
We will not.
tachycardia, I will not.
He came
Right.
walking or he came on a trolley?
Sir, he is stable, I said.
Stable,
He's
So
she
that
said.
is what
walking,
we, that
right?
even with the
So-
figures of 4 and
Walking.
5, we don't worry.
No,
So
you
I
just
was-
give iron and keep him under
I was-
observation maybe
I
for
was
2
nasty
nights.
when
and-
taking round in Wadia. The resident has given a transfusion to an iron deficiency with 3 gram. He would write very quietly, HJ I was positive JVP rate because I'm going to fire him that where was the impending failure. So he will
Right,
then
right,
make up the story.
Make it out.
So there's no
Sir-
cutoff for chronic anemia
No.
like iron deficiency which can be cured or sort of
So
reversed with
stable
good
child
drugs.
with deficiency anemias, we do
No,
not
so
transfuse but
over-
treat
So
them.
or occult failure.
one principle in transfusion therapy is wherever a substitute therapy is available, alternative therapy is available, and the patient is not going to succumb to the disease because you're not transfusing, do not transfuse. And single transfusions are generally not required.
Not required.
So I think that's a very good message that
So
we are going to
remember,
take back.
overt or occult failure is direct indication that
Yes.
you definitely. And second thing, if you're suspecting that there's going to be blood loss
Mm.
or there's
Yes.
going to be failure, like in a chemotherapy patient, massive chemo you are given, the marrow is going to shut down for some time, or there is associated infection, especially involving lung. You could be little more because the hypoxia is also adding to your low hemoglobin.
So that was
But
my
by
next
and
case,
large,
that suppose,
most
we are-
abuse is in nutrition anemia
right, right. So
and
children with-
surgical. There's nothing like a
Pre-op.
cutoff for surgery. In fact, I tell the surgeon friend that if you give transfusion, the chance of wound dehiscence or wound infection are
Is
higher
higher.
because of the lymphocyte of the donor going and attacking the immune system of the recipient, and they get very scared because no surgeon likes to have a wound infection.
In fact,
so sir has kind of answered
almost-
my next
almost
question.
all blood. Sorry, can I just put
Yeah,
in
yeah,
something
no
here?
problem.
Yes, sir.
Almost all good blood banks have started doing what is known as MS-BOSS. MS-BOSS is maximally required blood for any given surgery. For example, if you have a hip transplant, you require about 3 transfusions. So you ask your surgeon to cross-match and save CS. So your blood is in the blood bank. Whenever you need it, you bring it to the OT and give it. But otherwise, you leave it in the blood bank. So in case you don't need it, it can be reutilized for somebody else.
Yeah,
And that is
uh,
based on the MS-BOSS.
And the other
So-
thing you can do is actually when you are anticipating a blood loss, like in orthopedic surgery, you should do intraoperative dilution of the blood by giving more saline in a
Oh,
otherwise stable
autologous.
cardiorespiratory patient. So whatever loss happens, you dilute it. So you actually don't lose too much of hemoglobin, and you can transfuse him. Then the cross-match blood, as Dr. Nupam said, you will probably need lesser number of units than what you need otherwise.
Yeah.
Actually,
So,
the
sir,
pediatricians are very sensitive to this sort of thing of not giving blood. I'll tell you my own story, and that is that when I was sick, our physicians were very aggressive in advising blood transfusion to me, and I used to crib lying down in the bed. My wife would say, "You are no more a doctor. Please behave like a patient." So that was a constant crib with me. Uh, I mean, I've received so many transfusions in the last few years that,
so
so
I think, sir, some takeaway messages for
Yeah.
our general pediatricians from this packed red cells is that pre-op fitness, even if it is a 8 gram%, will not merit a blood transfusion. A stable child at any level will not merit a blood transfusion unless there is an underlying factor with a chronic lung disease or a chronic liver disease or is under chemotherapy or radiation therapy. Then there are few guidelines that we need to follow and we stick by that.
I
So I
want to
think
just
before,
add one more thing on that. That if
right,
you have
sir.
a patient with non-obstructed hernia or a circumcision or a cyst removal, comes with 5 gram hemoglobin, you don't want to lose the patient, so you transfer into surgery is the biggest crime.
abs-
Mm-hmm.
Because you can always give, most likely it's going to be behind. If you give them therapy, wait for 2-3 months.
Elect.
Surgeons get very worried of letting the patient go. And I always tell them then, see again, same thing. You transfuse and do it and the patient has wound infection, you'll have more problem. I think we need to teach our surgeons that transfusions are not required every time the hemoglobin is low. You can wait and let the hemoglobin rise on its own.
So, unless one goes through transfusion oneself, one doesn't realize this problem. I have
Oh,
undergone
God.
transfusion in emergency in New York.
Oh.
And when I told my, treating physician that don't transfuse me because I'm scared. I have been into HIV for so long as an expert that I might get HIV, I might get HCV. And when the blood was dripping down, I was thinking, इसमें HCV होगा, इसमें HIV होगा, क्या पता क्या होगा, some prion protein disease होगा बाद में, शायद इसीलिए memory कम हो गया होगा, पता नहीं. So all this comes to your mind when you are receiving a transfusion, but that sensitivity one has to develop for your own patients also equally. So don't give unless mandatory. Don't give unless mandatory should be the message today.
So two important questions that are left for whole blood and packed red cells. One, what number of IV cannula ideally would you prefer with an ideal IV transfusion set? And second would be, is a pre and a post transfusion Lasix? This is a question that has come up from one of the viewers
My
also.
God, this I
You
will
need
love
ask
to
I think-
answer.
you need ask for
This I-
F-call in an Evil.
I will answer this because this is one of my favorite irritating answers. No Lasix is required unless the patient is in impending cardiac failure or cardiac failure. That too, very, very sparingly we use it. Very sparingly. In no thalassemia patients we have ever used Lasix as a routine pre-transfusion. That is the first thing. Now, second thing you said was cannula.
Cannula size.
So it varies. If it's a very young child, I may even go for 21 cannula, 22 cannula. But ideal is 20.
20.
Even better is 18 because you want the blood to run smoothly through and not clog. Especially when you're using filters, leucofilters, there's a difficulty in getting the blood through. And that is the reason pre-storage is better than the bedside leucofilters.
Bedside.
There's also something called laboratory filtration where you actually do not do it while you are transfusing, but just before releasing the blood from the blood bank. And you just put one bag to another through a filter and pass on the blood into the other bag. And then the patient will receive it very smoothly.
The only problem will come in a newborn where you may not be able to put anything more than 24 number.
Yeah, that
Packed
will of
cell
course
may
be.
not flow through easily, but you
Yeah.
can take help of a syringe pump, which will
Yeah.
keep a good constant pressure and probably you will not have trouble.
So I
newborns
think
as well.
because Madam has agreed very graciously that 15 minutes extra, even Dr. Sachdev is unwell. We have 15 minutes and we will take up fresh frozen plasma as our next component.
Mhm.
So
Platelet is a big topic, sir. Both of
Mhm.
you will have to give permission for a second
Sure.
turn also of this. So I think Samir bhai can
Yeah.
take up fresh
And
frozen.
for all the questions that have been asked by the audience, I have a suggestion at the end. But meanwhile, let's do a rapid fire round with both our experts about fresh frozen plasma. So, Mamta ma'am, what are the contents, volume per unit, and storage and shelf life?
So the contents of fresh frozen plasma obviously is the plasma proteins, plasma fluid, and we have factors, coagulant factors. We have various, anticoagulants in it. antithrombin 3, protein C, protein S. These are the contents. Albumin, of course, is there, but it is very little in every bag. You know, in the whole body, we have 4 gram percent. So you will get about 4 to 8 grams from a bag of plasma. And the quantity is about 250 ml. And again, it depends. If you do apheresis plasma, you may be able to get 500 ml quantity also. So storage is always frozen. So it is below minus 80 degrees. And in the blood bank, so when the blood bank releases it, it thaws and gives you. And once thawed, it should never be refrozen. And it has to be used promptly within 15 to 30 minutes once received in the wards.
Thank you. Dr. Nitin Shah, sir, how to use it after it's issued from the blood bank?
So as Dr. Mumtaz said, it has to come thawed to you. If it's not thawed, then that's not a good blood bank. Run it very fast because the factor 7 has a half-life of only few hours, 2 to 3 hours. Factor 8 is 8 to 12 hours. So if you keep on hanging, again the problem. Second thing, if look at the bag, that there are no micro breaks, so that you have to then return such bags. And any leftover has to be discarded. You cannot store it in your refrigerator. Blood is a drug, and the only license to store that drug is with the blood bank. So you can't bring some fresh frozen plasma and keep in your deep refrigerator, even if you're minus 20, because you're not allowed to do it. All right. So do not keep it. I mean, if you have brought a thawed FFP and suppose you don't need to use it immediately, you shouldn't have asked for it. All right. So that's the bottom line, that you should use it like that. And
So even in a rare
and
case
give
of a
15
newborn,
cc per kg at one time. Don't exceed more than that, because you can induce failure, because it is just a lot of plasma protein and albumin. If you can give maximum 2 times a day in a patient who is not in cardiac failure, okay. And when you give 1 ml per kg of FFP, you raise factor level by 1% if it is 2% if it is factor 8, and 1% if it is factor 9. That's the general dictum, and generally it has 1 unit per ml of FFP of most of the factors. Yeah, and
so
for
even
factor
for a
13,
newborn,
for factor 13, you need to give it only once in 3 to 4 weeks, because the half-life is so long.
so for a newborn, so if you're ordering for some reason an FFP, you're ordering a whole unit, but you will never be able to reuse it, as you said.
Yes.
So you have used it and discarded.
Yes.
Right.
Madam, you were saying
generally you should remember FFP is available in plenty, because the use of Paxil is more, platelet is even more. FFP is not that much. So that's why so much of FFP actually goes into making IVIG, albumin, and other products. No? So FFP, even if you have to sort of little wasted, it's okay ethically.
So unless you have an unknown factor deficiency or a patient with a coagulopathy where you don't know what is the actual deficiency, don't use fresh frozen plasma. Use the factors that are available, factor 8 for hemophilia A and 9 for hemophilia B. You have also now factor 7 available. You also have fibrinogen concentrate. So use specific ones rather than, and cryo itself is a good therapy if you can't afford the fibrinogen concentrate. Cryo contains factor 8, von Willebrand factor, as well as factor fibrinogen. So use those rather than using fresh frozen plasma, because the volume in a cryoprecipitator is just 25 ml per bag, and it contains good amount of fibrinogen up to 250 milligrams. So use that.
Okay. So Dr. Nitin Shah, sir, quickly, what are the absolute indications and absolute contraindications?
So, as Dr. Mumtaz said, first time a hemophiliac patient has come bleeding, you don't know which factor 8 or factor 9. If you're in a good hospital, the hemat lab will immediately tell you within half an hour is factor 8 or factor 9. If that's not possible, abort that bleeding by giving FFP. Second use of FFP is in a patient of preterm with hemorrhagic disease of newborn, because there, though even if you vitamin K, because the proteins are not as formed, because the liver is immature in a preterm, you may have to replace also the protein by giving FFP. So these are the two major indication of giving FFP. Besides giving FFP for plasmapheresis in a patient with, say, ADMTS enzyme deficiency, or sometimes like in other, most of the time where you are doing plasmapheresis, you actually use saline or albumin. But in certain cases of ACLA syndrome, where you want to also give them the anticoagulant factors, then that time you use FFP as a replacement for doing a plasmapheresis. And lastly, you use FFP for any bleeding disorder which has come for the first time. As I said, you don't know what the cause is. In a patient of, say, liver failure, cirrhosis, and you want to do a liver biopsy, procedure, then you may have to give FFP. And in a DIC, where there is massive bleeding, you have to give everything because you have to give FFP, you have to give them the platelet, and you have to also give them the packed cells. So generally, these are the broad, but it's most often misused as albumin. Most often uses in preterm to build up the protein level, in a SAM patient to build up protein level, in a non-hemorrhagic disease of newborn in a full term where you don't need it, just need vitamin K. So these are the few misuses. So there's more misuse of FFP than actual use in our day-to-day practice.
Madam, any special situations for using in newborn?
So in newborn, as we said, vitamin K deficiency, where preterms, where you can do not, vitamin K takes about 2 to 4 hours at least to revert the prothrombin time. And therefore, you can't wait in a preterm who is already bleeding profusely. There you would use. Otherwise, in any bleeding which is not clear, DIC, liver disease, all the same indications as already Nitin has alluded to.
Yeah.
Also,
Madam,
if you have
your
a full
Couple
term,
of
if you have a full
points.
term, if you have a full term with hemorrhagic disease of newborn who is massively bleeding,
Then you need to
then
give.
you can't wait for vitamin K to work,
Vitamin
especially if
K.
CNS bleed, because that can be devastating. Yeah, Danupam, you are saying something.
Yeah, one area where we can use it is purpura fulminans in the neonates, FFP,
Yes.
where it
Yes.
can be used, but only with a big caution there. And the other thing is, the other thing is that if you have a patient with liver disease and you're giving FFP, the patient is not responding, think of giving cryo, because in liver disease, fibrinogen levels are very, very low, and you may need to give cryo to build up the fibrinogen levels and stop the bleeding.
The other thing, I mean, rarely you may not have hemophilia A and B where you have factor available. You may have factor 10 deficiency, like by
Exactly.
IBR deficient. You don't have factor 10 concentrates available. You will have
So
to use FFP.
FFP.
But remember, when you give again, when I said you give 1 ml per kg, you raise level by 1%.
1%.
So at the most you can give 15 cc per kg. So you raise the level of that factor only 15%. So you have a CNS bleed in a patient, you need to raise it to 50, 60, 80, 100%. Never possible without volume overload. So it's not a good drug unless you are pushed to the wall.
So
So,
plasmapheresis for one more condition that pushes you to the wall is cold antibody disease, which is not common, but it is when it happens, it does not respond to any of your routine medications, IVIG, steroids, and you might be pushed to do plasmapheresis. And TTP, of course, which already Nitin mentioned.
HUSTT.
Madam,
Yeah.
one question on plasma, last one. Where do you order for a specific plasma from a male person as compared to a female person? Male plasma is advantage over a female plasma for...
Yeah, so it is simple because when females who are in the reproductive age group, these are the ones who can donate, right? And they can be multiparous, they can have had abortions, they could have antibodies to various antigens, and that can lead to,
Specific to females.
yeah, and that can lead to complications and reactions. Therefore, you prefer always a healthy male, but always in transplant setting, we say age is more important than male or female.
Right.
So that's
So
another
Samir
story.
bhai, I think
So,
for the
yeah.
benefit of maximum people joined here, let's quickly finish up the platelet also.
No,
So I
Or you
mean,
want to take the
there are
questions
questions
from
in
the
the
audience?
chat box.
Audience.
so
Yeah,
then
I think
platelets
you
will
can't finish
rise yourself.
platelet in 7 minutes.
No, I don't think you should do platelets. Do the
Okay.
questions of the
Let's take
audience.
the questions asked by the
Sure.
You
audience.
can only
Sure.
you can only finish giving one platelet in 7 to 10 minutes, but not discussion about
I
platelet.
agree. Okay, sir.
That also takes 15 to 30
15
minutes.
minutes.
No, and
Yes.
I'm
Okay.
happy we still
Yes,
have more
Samir
than
bhai.
110 people. So let's have a quick rapid fire round from the audience. And
Chat
there are
box dekho.
two more interesting things to
Yes.
tell you for the next program. So please hang on, don't leave yet. Yeah. Neil, go ahead, take the questions.
I'll go through if you have something quickly. Okay, this is fine.
And there was a question in a SAM patient with hemoglobin 5 cutoff for transfusion.
What to do in SAM with hemoglobin
Ah.
less than 5? Very compliance with iron is very poor. Dr. Arora.
So do you recommend Paxil's transfusion in such a child?
So you have to be careful. And of course, you may transfuse because 5 is too low and all the tissues will have hypoxia and therefore they will not heal properly. So you may give, but give restrictive transfusions. Do not overdo. That's the dictum in a SAM. And don't give too much fluid. Don't give too much fluid. Be careful when infusing the packed red cells also.
Second question that is many times asked is what is the cutoff in malaria, severe malaria? So WHO says 4 grams and below, but I would say again, more go by occult and overt failure rather than
Clinically.
Correct.
So I think
Clinical.
Dr. G has asked few words on autologous blood transfusion. Nitin Shah sir already said a little bit, sir, but if you can address that.
I think anyone with more than 10 years and more than 20 kilos actually can happen, but it is somehow not picked up in our country, or for that matter, because of the availability of safe blood with so many voluntary donors. But ideally, in past, people used to do that: you donate one blood, then after some time you take that bottle, you donate two blood. All that is given up now. It is mainly you donate for your own self, and during surgery you have intraoperative dilution, and then you take back that unit, and that it is usually in orthopedic surgery rather than in general principle. But as I said, with the advent of
Electives.
safe blood product, most of the people don't do it.
So one of our participants has asked that suppose you have a child with very, very low hemoglobin and we have to use 2 units of packed red cells. Can we do it in a single cycle of transfusion back to back?
So it depends on the weight of the child. No, if you have an
Yeah.
adult, they will always give 2 units. They
Yeah.
will never give one. It's 15 cc per kg. No, so suppose the child is 30 kilo, you need 450 ml. So he will probably need 2 Paxil of 225. They can be given if he's not in failure in 3 to 4 hours. You don't have to give each one over 3 hours.
Right.
But if
Yeah,
it's a
but if
failure,
they are,
don't
yeah,
use
then
it. Use small volumes.
no, and then you will use about 2 to 3 ml per kg per
Correct. So
hour.
you start
Lesser,
with 5 ml per
lesser.
kg. There's no hurry at all.
Yeah.
Remember one thing, and I'm telling you, we have a patient. You are supposed for some reason 3 gram hemoglobin and you are transfusing. You give morning 15 cc, night 15 cc, next day 15 cc. For sure, by next day night he will converge and come to your clinic.
Yeah,
Ah,
Or will.
hyperviscosity.
So
right, sir.
should never do.
They have
Never.
strokes.
You tide over the crisis of failure by giving a small alicot of 5 to 10 cc. That's enough. Then there's no hurry, no big hurry
Yeah.
to really keep it to 14 in 2 days time.
Right.
No, you can wait for a week and repeat. In fact, we used to
Absolutely.
repeat weekly in such patients because
It's better to wait,
hyperviscosity is
urge
known.
slowly rather than being
Yeah.
too hasty.
Because it is known, strokes are known with hyperviscosity. In those patients, you raise the hemoglobin too quickly.
Madam, we have a colleague here who's asking, just tell us when will we give Lasix? We learned that we are not supposed to use,
Cardiac
but is there
failure.
any only in failure you will like to give
Failure,
it as a
impending
pre-trans?
failure and failure, you may give a small dose of Lasix before starting the transfusion.
If they have received steroids somewhere,
Again, I have actually in practice not used Lasix even in patients with
even in a child with
impending
impending
failure.
failure.
If you give slow transfusion, as I said, 1 to 2 ml per kg per hour or up to 3 ml per kg per hour, they do not get pushed into failure.
See,
So Lasix
use
is
of-
really not required in pediatric practice.
Use of Lasix in a patient of this type of condition is to treat the CCF and not because you're giving blood. You give smaller alicard and build it over gradually. I mean, that's the bottom line.
Right.
And never use Avil as a routine unless there's reaction. If you are using a pre-filtered blood or a bedside filter, you will rarely require. In fact, I've never used it in last 10 years in Hinduja Hospital, and never give steroid, Epcorlin, Dexa, nothing. No need to give. They are not magic drug. They work like this. Even if you give a steroid, it takes 8 to 10 hours for its action to start. So someone has a reaction now, giving steroid is not going to help. And
Also, if you give steroids and if it was a leukemia with anemia, you can push them into remission, which can come back after 2-3 months as a relapsed leukemia, and you're upstaging the leukemia and giving a worse prognosis to the patient. So please, like in ITP, we say don't use steroids, without it, irrationally. Similarly, here also.
One
So
practical tip, Nehal, is when the transfusion is happening, at least a nurse should be around, if not a doctor also. You have to check the pulse BP before starting, in between, and monitor, and ask the patient if he has fever, shivering, or a back pain, or a blood in the urine. He must cola colored urine. He must immediately report. It could be transfusion reaction because of mismatch, and the blood has to be immediately stopped, whatever. And don't use it after 1 hour. The shivering goes again. Restart. No, return that blood along with a fresh sample of the patient and with a AER form filled that a suspected blood reaction has happened, and they will investigate: is the correct blood group? Was there a minor blood group? What was the reason? So
So you mentioned back pain. Why back
pain is when they have hemolysis, intravascular hemolysis. First thing is the renal involvement. So they have severe back pain.
Right.
And then they will have cola colored urine.
So how long to wait for the bone?
Same thing I wanted to emphasize. First 15 minutes of transfusion should always be slow, whatever you are giving, because with that you will know whether there's any incompatibility, any reactions happening. If anything happens during that time, then abandon the transfusion. If nothing happens, then you can give at the rate you wish to give.
Perfect.
So,
Sir,
one thing I want to reiterate again and again, which ma'am and Nitin have also said, that is the most dangerous thing to use in a patient is blood and its components. So you have to be damn careful. Your recording of your patient's case history and everything should be absolutely picture perfect. I've got at least 3 medical legal cases in which I've appeared as an expert where transfusion problems were there and the notes were atrocious. So we need to make sure that our notes and our documentation should be excellent. I mean, that goes without saying for everything, but especially for blood transfusion.
I
So
will
it has
just
to
sure.
be excellent.
I will just add one thing, Nehal, that how come that I used to treat HIV patient. Dr. Mumta became HIV expert with an center of excellence because we used to have HIV in blood transfusion patients.
Absolutely.
So that was the danger. We used to have hepatitis B in an onco patient. He become okay from leukemia, goes into chronic liver disease.
Yes.
I mean, it's pathetic that you have made him from deep sea to the devil. Fortunately, all that is not happening now. But you never know what a future disease may come out of blood products. So the bottom line is, do not use blood product unless they are absolutely required. I mean,
There
there is
was
no
a
question.
2-year-old child with nephrotic syndrome given FFP for albumin in a very good tertiary care institute in Mumbai city. That child became HIV infected. We lost him
Yeah.
at 15 years due to resistant HIV
Oh, I
infection.
know that case.
Yeah, I
Sir,
don't want to mention anything further.
sir, Bombay blood group. Can you say something about Bombay blood group? Somebody's
Yes.
asked us about.
Yes.
So this
So,
is a very rare blood. Okay, go ahead, Dr. Manta, you want to
so
say?
it is a O group with the H antigen positive and which is negative in normally O group patients. Once you have that positive, it triggers a reaction in any O patient who is actually not having the H antigen. So it is a deadly thing to happen because it is not easily detected unless the blood bank is doing that regularly.
Right,
And
right.
it is a rare phenotype. And when you are an O, Bombay O, you need sometimes a transfusion. You have to really look out for donors
Somebody
all
who's
across the country. In fact, Vinay Shetty, who is one of the persons who does all this work, he has been transporting Bombay O group blood bags to Nepal, to Thailand, to Burma, to where all.
I'm glad you
From
mentioned his name.
yeah,
I'm glad
yeah,
because there are so many such angels who don't get the same
yeah,
credit as doctors or others who
yeah.
are
But he does
really
wonderful work.
Vinay
So,
Shetty.
so
Yes,
Bombay blood
he has a
was
list of all Bombay blood group
Hmm.
donors, and their
Hmm.
the donors are so nice. I don't know, they are more angelic than him. Also, they come at the drop of a hat to donate the blood when
Readily,
required, very
readily,
ready.
very
Similarly for
readily.
platelets. So anybody needs any blood component in emergency, either for their own self, family, or even patients, please don't hesitate to contact him. He is always available.
Just type
so
his number,
Bombay
madam.
blood group BGRC, the Bombay Group Research
BG.
Center in KEM was the first to invent this blood group. That's why it's known as Bombay blood group.
Dr.
And
H.M. Bhatia.
you cannot transfuse a Bombay blood group patient on
With
your indication. You have to suggest, a team will come and ascertain whether you actually need it because it's such a rare blood group. They don't want you to waste the donors. I remember when I was a resident in Sion Hospital, we had one patient, KEM blood banks, 2, 4, 5 people will come, ascertain the patient need, and then they will bring a donor and bleed him and give it to you. And of course, there are famous movies where criminals have been caught because they were supposed to be Bombay blood group negative, and they said fresh blood was taken from some other city, so that's how they caught it. So this is of course a story, but I'm just
So,
saying that this is rare, but it is very, very exciting and devastating.
so we'll share Mr. Vinay
Yeah,
Shetty's
I'm
number
typing
on the
it right
group
now.
then. And
So
last, yes, very good.
you have the
Thanks.
number? You
Yeah,
have
I
the
typed
Before
number?
it already. It's
before
there
you
in the
finish,
chat box.
Yeah.
I
So
want to give
last
one
Yeah,
question,
we
message.
sir,
have to
last
ask
Before you
question,
Dr.
finish,
one
I want to
Dr.
give one
question.
Arupal
message.
Sajde for
Yes,
his point of view.
Sir,
yes.
1 minute, one
Yeah.
minute, sir. One common question, because congenital heart diseases are something that general pediatricians deal with. Somebody's asked, what is the average optimal level of hemoglobin to be maintained in these children?
It's a normal hemoglobin of the child's age. Why would it
14.
mean congenital heart is not going to, unless it's a cyanotic heart disease,
Cyanotic.
his hemoglobin will be very high. Then you will not want to keep a polycythemia in that patient. You may have to do bloodletting. That's a different issue. If you have a patient of, say, pallotetralogy and his hemoglobin is 10, for sure he's got iron deficiency. He's supposed to be 14 and 15. So there is nothing like that because he has congenital heart, you need a separate type of. Of course, if he's a congenital heart disease like VHD who goes into often failure, and now he has come with 8 gram hemoglobin is failure, you won't transfuse it.
You
That's
will
okay.
to high super oxygenate the blood by
Absolutely,
raising his.
absolutely,
Sure, sir.
Around 11.5 grams you can maintain it. And in a congenital cyanotic heart disease, sometimes even the
14.
hemoglobin may not drop.
Yeah.
And you may have iron deficiency, which is causing him
Smear.
easy fatigability and
Smear.
other symptoms. Look at the smear and look at the MCV and MCH, RDW, etc., and diagnose it, not on the
Treat
basis
that.
of hemoglobin.
So we didn't
And
discuss
14
very.
is the general cutoff you must
So we didn't
maintain.
discuss very sick patient, but generally a patient who needs oxygen, you should keep him normal hemoglobin. If he's on a ventilator, don't keep very high because lung damage is more common. So you can tolerate even 9 and 10 in a child. In ECMO, you will keep it above 12 or 14, and in a congenital heart, 14. I mean congenital cyanotic heart.
Cyanotic.
Cyanotic hearts. Sure. Sure. Samir bhai.
No, we
So-
have to come to Dr. Anupam Sachdev for his point of view. Just
I
before,
want to give one message before Anupam says.
yes, yes.
And I want to motivate. Now I'm turning 65 in August. I must have donated blood at least 20, 30, 40 times. I've lost count. I don't keep count because I mean numbers, we don't want to brag. If I might have helped some patient to survive. Now on this August, I'll complete 65. Today is my last chance to donate. I donated 3 months back and one more time 3 months back. So I'm doing it every 3 months is last 1 year because I know now they won't take after August. I'm going to do it on this Saturday, which is the blood donation day,
World
World
Blood
Blood
Donor
Donation Day. This Saturday, I'm going to donate for my last
14
time
June.
in my life. And I'm fighting with the blood banks that please make a consortium to say that people who are healthy like me should be allowed to donate beyond 65 because internationally there is no cutoff of 65. It's based on your condition. So my plea is that this Saturday, please, all of you who are below 65, who are healthy, who have no issues, who have no fear of donating, even if you have fear of donating, donate for the first time, you will understand. Please go and donate blood because blood is something which you cannot make in factory. You have to donate it to save life. And I'm telling you, survival of neonates, especially preemies, in the tertiary care NICUs and survival of onco patient is only because of
Blood.
availability of good
Thalassemia.
blood components. Yes, all
Thalassemia
hematonco, all hematonco.
So
Yeah,
one
so-
message which I'll also give after you finish.
Yeah, no, I finished. So please go
Okay.
and donate. I'm going to do it. Will you?
Yes.
So be a stem cell donor too. There you don't
Yes.
have to actually give away your stem cells the moment you become a donor. Blood, at least you will go and give and you will become a donor. Here you have to pledge to become a donor and you will be called only by luck if you are matching with someone's HLA. And that
Yes.
becomes a very rare event. 1 in a lakh population, you will match with the person who is not related to you. So just register. There are many registries, DKMS, Datri, Jeevan. Please go on the websites and see how to become a donor and become a donor, because when you will give marrow cells to a patient, you will feel extraordinarily great and fulfilled. And we have a pediatric hematologist who gave to a patient of immunodeficiency, and that patient stays in Borivali. So when she came to our center, that patient found out and came to meet her and brought some great food for her. That is the least, of course, but the satisfaction of the two donor and recipient meeting was extraordinary. I mean, I was really impressed. So please do that also.
Thank
Okay.
you, madam.
Thank you very
Yes, sir.
much. Before we go to Dr. Anupam Sachdev sir for his point of view of the whole topic that we spoke, quickly just want to make two announcements that we would be very happy to share with you. We are starting a new webinar series from next Wednesday, and the series is titled Smart Pediatrician. We know all of you are smart. It's only to get everybody smarter from point of view of being strategic, mindful of what we do, aware of situations around us which are very dangerous nowadays, be resilient to all the stress that we feel in our profession, and at the same time be tech savvy to make our lives easier, helpful, and happier. So this is launching on the 18th of June, that is next Wednesday, 9 p.m. So make sure all of you stay tuned in. It will cover all non-clinical topics that will help your life make it better. And many of you had asked questions which we could not answer. So we are going to come up with this 1 minute wisdom from experts. Please send your questions to us. Mention who is the expert you would like to answer that question, whether they are from this panel or even outside, because it could be topics besides hematong, and we'll try and get you that expert to answer your question. So I've put the number there as well. Now it's over to Dr. Anupam Sachdev sir for his expert point of view.
Yeah. Well, I've been pitching in between also, and I would concur with both the experts for their excellent, answering of the things. Only thing which I would like to add is that for patients who have severe anemia, let's say 3 grams hemoglobin, the maximum patch cells which you should give is 2 into 3 is equivalent to 6 ml per kilogram body weight in one sitting. And that will prevent your congestive heart failure in a big way. Of course, the blood has to be given over 3 to 4 hours, but not more than 6 ml per kilogram in one sitting if a patient's hemoglobin is 3 grams. I mean, it's a uh, rule of the thumb or a mnemonic which we use, but it's of great help in the wards where we can make a diagnosis and give the treatment properly. And another thing which I would like to say is use blood. I've already said it, but use blood judiciously and with great care, because it is a very uh, scarce product, one. Number two, it should not be used unnecessarily. And do treat the patient, but don't treat your anxiety. Thank you.
Thank you, sir.
Thank you so much,
So
sir.
over to our
In spite of your health
No,
concerns, you are here, and like we said, I
no,
think that comment
One-
entails for
concur
all
One
of
with
last comment.
what Anupam said, that every time you have a new batch of resident, your transfusion levels go up. Moment they get trained, it comes down, and so that's true also for a new consultant.
One last message, always take consent before giving transfusion. This is a mandatory law. Please do not avoid that. And of
Written
course,
mandate.
whenever you are using blood in your hospital, have an audit annually so that you realize whether you used it judiciously or not on your own, for your own conscience, so that you'll improve every time with
Sure.
that. Thank you.
So
Thank you.
over to
Thank-
our secretary, Dr. Sikha now. Sikha will give us a vote of thanks.
So I think it's a beautiful session that has been held, and it's a heartfelt thanks to Mamta Madam and of course Nitin Sir for wonderfully enlightening us so patiently and addressing all the queries related to transmission, which of course was very, very well moderated by Nehal Madam and Sameer Sir for the rapid fire questions that he had. A heartfelt thanks to Anupam Sir as well for giving the key messages as well and also pitching in between. So thank you so much for a wonderful session to the faculty, to the moderator, and for Anupam sir for the point of view, and of course for the 3 key messages that were given by everyone. Also, a big thanks to the delegates, all the who have joined and have been there till this time. More than 100 people are there with us as yet. So thank you so much for this from on
Friends,
behalf
we
of all
have
IIT Mumbai.
one CME coming up on this Sunday, which is at Surya Hospital, which is a multi-speciality CME. And we have one on the 22nd of this month, which is Encyclopedia 3.0 on all about practical aspects by none other than 2 great teachers, Dr. Chokhani and Dr. Amdekar sir. So we are circulating messages and flyers. Please register for the same. And
the
Madam,
Navi
special
MPCon. And
thanks
the
to
Navi
you.
MPCon. And the
Without
Navi
dinner,
MPCon.
you have stayed back. Thank you so
No,
much.
no, no. It's
Yes,
fine.
sir.
It's fine.
And
Navi
of course,
MBCon.
Navi
yes, and
MPCon
of course
Plus.
we have
Yeah.
a different kind of an annual conference this time with Mumbai, Navi Mumbai, Palghar, and Raigad
Raigad.
all
And
joining in together and doing a Navi MBCon Plus, which is going to be on the 13th and 14th of September. So stay tuned and register for the same. It's really going to be a good scientific treat. Thank you.
Thank you,
Thank
everybody.
you, everybody.
Thank
good
you.
night.
Thank you
very
very
much.
Thank you,
much.
madam.
Good
Thank you,
night.
sir.
Thank
Thank you
you.
so much.
Thank you,
Bye-bye.
everyone.
Thank you, sir.
Bye.
Bye-bye.